Thank you for having me come and speak to this topic. As you can see, I wear several hats. I've just come from the Ottawa Hospital, and I'm driving on to Cornwall and past the Winchester Clinic, so I move around a fair bit. I see a lot of people who have falls, and just by necessity, I've developed an approach to falls. I've had to adapt it for the algorithm, but all of the elements are in there. So even though I went through internal medicine, geriatric medicine training, I wasn't given a comprehensive approach to the assessment of falls. So if you're feeling like you didn't get that education, you're not alone. We're all really in the same boat. So just to highlight how important falls are, it's estimated 1 in 3 seniors are likely to fall at least once per year. So high volume. It's the most common cause of injury and the 6th leading cause of death for seniors. That's something many people don't know. So not only is it common, but it's very dangerous. Every 10 minutes, at least one older adult visits the emergency department due to falls. So this is really an emergency department diversion strategy, trying to prevent admissions to hospital, prevent presentations to emergency departments. And despite that, every 30 minutes in Ontario, one older adult is admitted to hospital with a fall. So it's a big flow issue for hospitals. And when people fall, many of them don't recover fully or take a long time to recover. And really, if you look at the overall economics, falls are the leading cause of overall injury costs in Canada, so $6.2 billion, or 31% of total costs for injuries. So this is a high volume, very dangerous, very expensive issue that unfortunately we haven't really been trained to fully assess or to assess comprehensively, and we haven't put adequate systems in place to deal with this. So I commend the Ministry of Health and trying to get a fall strategy up and running, and pilots like this are going to be key to developing that strategy. So we're going to be asking you for a lot of feedback and a lot of input on where the strategy goes from here on in. So you are drivers of change. In terms of being an expert in falls, I'm going to start by contradicting Jane. There are no experts in falls. There are a lot of students. Some of us have studied a bit longer than others, really students. So the good news is about 1/3 of fall-related adverse outcomes are preventable, so it's not as bleak as the previous slide suggested. And I would suggest employing a vital sign concept. If someone has not been falling or having near falls and they're starting to have near falls or falls, something medical has changed. They've been put on a new medication or they have a new medical condition. So think of it the way you would a temperature, a high respiratory status, a very fast heart rate. It means something has happened medically. So that's a whole different way to look at falls. So if your patient starts falling, something has happened, you need to start examining them. How to examine them is pretty complicated. So why is it so complicated? Why is it so difficult to assess, aside from the last point that it's really not a part of our medical curriculum? Number one, just standing upright is a very unnatural position. There are no other mammals that spend their lives on their hind legs trotting around. Human beings are the only mammals, to the best of my knowledge, that do that. At one of these presentations, I'm sure I'll be corrected, and there'll be some rare animal that does. And so balance requires very complex integration of the cardiovascular system and the neurological system. And that type of high-level integration can be tipped over by multiple problems: vertigo, strokes, cardiac issues, neurological issues, neck disorders, physical deconditioning, medication. The list goes on. The causes really cover about 8 to 9 medical specialties, and you're going to see there's about 150 to 200 causes of falls. So this is a very, very complex area, probably one of the most complex clinical areas around. So you've all seen the algorithm. What we realized as we worked on this algorithm and put it together, the yellow boxes are drawn from the American Geriatric Society and British Geriatric Society consensus guidelines. And what we realized are two things. Number one, the content was very good, especially box 5, but what was missing is the guidelines didn't describe how you would assess medications, how you would assess postural hypotension. They lacked the actual instructions regarding how you assess any of these. It was just assumed everyone knows how. And I'm not sure everyone knows how to assess each and every one of these. The other thing we noticed is in previous guidelines, some of the most common things were lower down on the list. So really the first thing you should be checking is postural blood pressure and medications, and those were lower down on the list. So while we didn't change the population of the box, we did change the order, so the highest yield items are at the very top and you're going to get to them first. And you'll have to tell us if that was a good approach after the pilot is done. You've seen the multifactorial risk assessment for falls page. That's been part of the workshops, and the stain independent checklist. So I won't go over those. So I will be focusing on box 5. And by virtue of the fact that the interventions box 6 come out of what you find in box 5, consider it kind of a joint presentation. But really, I'm going to be walking through box 5 one step at a time, and that really represents the overall outline for the talk. So, as I said, we took the guidelines, we changed the order based on patients we've seen. We see about 2,000 people with geriatric outreach per year, and many of them are falling, so we get a sense of what's common and what's less common. But really do view this as a process that you're involved in refining. So this is box 5, and I highlighted in red the 3 things that come up again and again and again when I review cases with the geriatric assessment outreach teams. One is medications that cause falls. It's incredible how many people we just have to ask the family physician to adjust 1 or 2 medications and their falls at least decrease in frequency. But you're going to see the list is not one that's really manageable just by physicians. We probably need pharmacists to become more involved in this initiative. Number 2, postural hypotension. Very, very common, but doing supine versus standing blood pressures is not something we do routinely in medicine. Even in acute care, it's not being done. Even in patients on dialysis in hospital, it's not being done, even though they're having 2-3 liters of fluid removed. So it's a real gap in medical evaluation. And the third red area is pain. We see a lot of people on geriatric outreach who are not walking well because of pain control. When you control the pain, they're already walking much better and falling less when they get to our geriatric day hospitals. So if you looked at that, those would be three high volume, high ticket items to not forget about. But we're going to walk through these one by one. You're going to see how complicated it is and why you really need a checklist to scan through. If you know your patients, you'll be able to walk through this very comprehensive list a lot faster than if you've never met the patient before, because you'll know what you can rule out very quickly. So in terms of medications, I'm going to give you a couple of slides, different ways to slice this problem. Number 1 is look at these 5 categories. So any medications that are deliriogenic, if that's a word, that's slow mentation, so those would be narcotics, benzodiazepines, alcohol, the anticholinergics, ditropan and detrol, and the tricyclic antidepressants. All of those can cause delirium. When people are delirious, they fall, break their hip, hit their head, have acquired brain injuries. So that's one category to look at immediately if someone's falling. The next are medications that drop your blood pressure when you go from lying to standing. I'm going to flesh this out further in another slide, but when I looked at the large body of medications, it took a while, but they seem to fall into these categories, and I call them all the antis: the antihypertensives, the anti-anginals, anti-Parkinsonian medications like Sinemet, antidepressants, the tricyclic antidepressants, the anticholinergic ones, antipsychotics, which are very anticholinergic, and the anti-BPH medications. Hytrin and Flomax can both drop blood pressure precipitously. Hytrin used to be a blood pressure medication before it was used for prostate. I have seen several men pass out on these medications. They're very, very powerful. Then the third category would be drugs that slow patients down and make them rigid and Parkinsonian. Those would be the antipsychotics. And then 2 gastrointestinal drugs, Stemetil and Maxiran. Stemetil is an old antipsychotic that's now used for nausea, and Maxiran is a motility agent. So those are medications you don't want someone to be on if they're already a little bit stiff and Parkinsonian. Number 4, vestibular toxicity, so high-dose aminoglycosides like gentamicin. That happens rarely, and high-dose loop diuretics like furosemide. More commonly, I should probably move SSRIs up on the list. There's a fairly large body of evidence linking SSRIs to falls, and I'm not really certain of the mechanism, but just be aware of that. You can slice this differently and focus just on delirium, and I've mentioned many of these, the deliriogenic drugs, benzos, narcotics, alcohol, antihistamines. So don't forget to ask what people are taking over the counter that they may not tell you about. People take antihistamines to help them get to sleep, and they can certainly contribute to falls, and many people fall when they get up and go to the washroom in the dark at night. The neuroleptics we've talked about, anti-seizure medication, so the anticonvulsants. All of them seem to affect the brain and often the cerebellum when the doses are in the mid to high ranges. So this would be Dilantin or phenytoin, gabapentin, pregabalin, so medications that we use for pain control, for chronic pain. One example in terms of how you have to look at the levels, not just the drug, is Dilantin. The therapeutic range when you look for Dilantin is 40 to 80. Seniors, when you go from 60 to 80, are actually somewhat Dilantin toxic. They get confused and they start falling down. So what we generally recommend is if the person's never been on Dilantin before and they're on it for seizure control, aim for a level of 40 to 60, 40 to 50 if you can. If they've been on it before, find out from their neurologist or their family doctor what level are their seizures controlled at. Some people have their seizures controlled at 20. So the lower boundary of the therapeutic range is really meaningless. You can go below the 40 and still have good seizure control. So find out what has worked for that person before. And if their albumin's very low, don't forget to get a free Dilantin level. Then anticholinergics. This is a really difficult area, problematic area, because physicians, generally we don't have a strong sense of all the medications that have anticholinergic properties. And when I look at the next slide, it's just daunting. You know, I don't think there's any way I can really work through a slide like this. It's nice to keep it maybe up on my office wall, but it's a very hard slide to work through. And it is incredible. There are a lot of drugs like Gravol that we don't think of as anticholinergic, but they are. And it might not be the one drug, it might be the overall anticholinergic load. As you're on a few mild anticholinergic, it might start to build up and build up. So how do you deal with a list like that? Well, first of all, I would go back. You know, you should be looking at the common culprits. So the ones on this page are the common culprits. Look for those medications. If you're not sure if there are other drugs and you really want to be comprehensive, look for a time-based relationship. So did the person become confused or start having near falls or falls after a medication was started or after a dose was increased? So that's a bit of a telltale sign. The other thing we don't do very well is we don't use pharmacists optimally. You know, pharmacists are doing med checks and doing a general review. I think where I find them really, really helpful is if I have a patient who is slightly delirious, confused, or is having near falls or falls. And I'll write a letter to the pharmacist. This person is having falls. Could you please list all their medications that could be contributing to the falls? If from the most likely to the least likely, I get fantastic letters back from the pharmacists. And then I can work through it. I can decide which medications are optional, which ones I can try to decrease in dose or stop, and which ones I cannot touch because the person's medical conditions would really go out of control. So I think that's a partnership that we haven't really established, what I would call strategic deprescribing, working with the pharmacists and having them do a problem-based med checks based on falls, confusion, urinary incontinence, loss of appetite. That's something we don't do very well, and I think it's something the province needs to look at as a new approach. So we've gotten through the first line, medications, and you're already getting a sense of how complicated this really is. The next high-ticket item to look at is postural hypotension. And if you look at the literature, you're going to see a lot of definitions, different definitions of postural hypotension. Essentially, it's the person goes from lying to standing, their blood pressure drops, and they have neurological symptoms. That's really the basic definition. So some people will say lightheadedness 1 to 3 minutes after standing. Well, if the person gets up, their blood pressure drops, and they're dizzy right away, you know, it doesn't take 1 minute, and I would call that postural hypotension. Then you look for neurological signs, dizziness, the weakness, the blacking out, the browning out, the heaviness, the headache, the heaviness in the shoulder area, nausea, perspiration. Look at whether when their blood pressure drops, their pulse increases, and I'll show you why that will help you work through the list. The traditional definitions are a drop of 20 millimeters of mercury in systolic BP and 10 diastolic. That's the American Academy of Neurology. I wouldn't be married to those numbers. As I said, if the drop is only 15 points, but you reproducibly create symptoms every time, I would still call that postural hypotension. So just be aware, a bunch of doctors sitting around a room coming up with a number and all voting for it doesn't mean that's reality. And be aware that this is very, very common. Maybe 1 in 3 seniors have postural hypotension. You'll have to decide if it's severe enough to be contributing to the falls. So we've published a precursor to this list. This is a list we created to really come up with all the causes of postural hypotension, and the list continues to grow. I find acronyms help me a lot, so I was very gratified that I could maintain a little acronym, so I called this the 4D aid. So what you're going to see is the first section. There's causes with compensatory tachycardia. Those are the 3 Ds. Now the 4 Ds. I have to change that. My apologies. And lower down, you see causes that present with lack of compensatory tachycardia, and that's aid. So when you stand the person up, if they stand up, their blood pressure drops, and they have a faster heart rate, they're in the first half of this slide. If their heart rate doesn't change, they're in the second half of the slide. So you can break it down very quickly. That's somewhat simplistic. People may have problems from both, but it helps me get through the slide. So number one in the 4Ds now, used to be 3Ds, now it's 4Ds, and it'll be 5Ds next time I present this because people keep on giving me another D. Number one is deconditioning. If someone's been lying in bed for 4 months because they've been waiting for a knee replacement, they're going to be very deconditioned. It may take weeks to months to get them reconditioned. If they've been lying in bed for 2 days after a hip replacement, they may be deconditioned, but you should be able to recondition them within a few days. So the scale of time to recondition should be somewhere around the same. Dysfunctional heart, that's the new D. So a myocardium that's not working, so a very poor left ventricular ejection fraction. So an ejection fraction, a normal one, looking at the size of the ventricle in diastole when it's relaxed and accepting blood, to systole when it's pushed out as much blood as it can, it should be ejecting about 55% of its volume. If it's only ejecting 40 to 55%, then we say that's mildly impaired. 20 to 40% is moderately impaired, and less than 20% is severely impaired. So if you have people who only have an ejection fraction of 20%, they often will not have a high blood pressure, even lying down, and then when they stand up, it really drops. And then aortic stenosis, even if their left ventricle is working well, if they have such severe aortic stenosis, usually less than 1 centimeter squared, then the heart may just not be able to get enough blood through that aortic valve to the brain. So then you're going to have postural hypotension also. So when we examine people with postural hypotension, the one murmur we always listen for is aortic stenosis murmurs. If you have aortic stenosis and you're starting to get postural hypotension, angina, heart failure, you're within your last few years of life, unless that aortic valve is replaced. So those are end-of-life symptoms. Dehydration, that makes sense. So dehydration could just be disease. You had pneumonia, you had a UTI, you were hypermetabolic, you lost a lot of fluid, you were doing a lot of sweating. It could be dialysis. As I say, I see a lot of inpatients who have dialysis. When people receive outpatient dialysis, they do postural blood pressures before they send them home. Some of our inpatient units do not do postural blood pressures after dialysis. So when we try to get them up and walk, they're dropping and their systolic blood pressures are 60 and 70. So because they come in sick, they're too sick to stand. Some dialysis units don't have that change in protocol that we really need. And then drugs, diuretics, so we've made people dry, or anorexic drugs. There are a number of drugs that can cause loss of appetite, but the common culprits are narcotics, digoxin, so then you lose your appetite, you don't drink, and your dig level goes higher and higher, so you go into a spiral. Antibiotics, all of them, but especially the sulfa antibiotics like Septra. And cholinesterase inhibitor. So we start these cholinesterase inhibitors for Alzheimer's. We tell families, tell us if there's loss of appetite, tell us if there's weight. We write it down, we remind them, and still people come in 30, 40 pounds lighter. They've lost a lot of weight, and they have severe postural hypotension. So these drugs do help, but they are a double-edged sword. They have some really serious side effects. And then the drugs I talked about, the 6 antis, so the antihypertensives, anti-anginals, anti-Parkinsonian, the anticholinergic, antidepressants, so those would be the tricyclics, the antipsychotics, and the anti-BPH meds. So the list up till now would be causes of postural hypotension that are associated with reflex tachycardia, so your heart rate goes up to compensate to get more blood out of the heart. The rest of the list is lack of compensatory tachycardia. So you stand up, blood pressure plummets, and the heart rate doesn't increase. So what can cause this? Autonomic dysfunction. So you see this in diabetics who have autonomic nerve damage, so autonomic neuropathy. If a person with diabetes already has peripheral neuropathy, they can't feel vibration sensor or proprioception in their toes, they're much more likely to have autonomic dysfunction. They have the start of nerve damage. Low B12, hypothyroidism, alcohol abuse, and then you'll see this in the Parkinson's disease, and we'll go through that list of Parkinsonism. And I'll drop to the bottom drugs. The one drug that can cause drops in blood pressure without a compensatory tachycardia is a beta blocker. So we had to move that out of the other section. If you can possibly find a patient that doesn't have any of these problems, that's a very rare situation, then you'd call it idiopathic. Often what I find the idiopathic is really someone who's developing diabetic autonomic neuropathy or Parkinsonism, and they start to declare in a few years. So it's just early on in their presentation and we can't pick up the concomitant disease. So that's postural hypotension in a nutshell. At the end, we're going to be talking about our regional geriatric program website, and we're going to try to populate it with as many resources as we can that will help you deal with things like postural hypotension. This is more the evaluation. Now we're moving into an area that, I'm going to give you a mea culpa that maybe I don't do as well as I should. So I learned a lot by reorganizing this presentation. And that's looking at gait balance mobility on its own. So what do? I was actually taught how to do this by my family doctor, because I asked him, what do you do? I'm really strapped for time. How do you assess balance? And, put his hand on my shoulder, and he brought me out to the waiting room, and he said, watch this, Frank. And he said, come here, Mrs. Jones. And then Mrs. Jones got out of the chair, and he described to me all the observations he was making as she was getting out, how she was using the arms of the chair, holding on to the loved one, how she leaned to the right, brought her into the room and let her sit down. So what do? I do go to the waiting room and walk people in and watch them walk, and I do a Romberg. I don't do get up and go, timed up and go in the 30-second chair test, but maybe I should. So we're going to describe these very quickly. We do want your opinion regarding whether these are useful in your practice. So this is part of the pilot where we're all learning from each other. Which of these tests are really, really helpful, and which ones are not as helpful, are you not really interested in doing? So the Romberg test, most of us are probably very familiar with. It's not a test of cerebellar dysfunction. It's more a test of proprioception. So what's being tested with the Romberg? So when your eyes are open, you're using 3 sensory systems to keep you upright, to provide input to the cerebellum. So that's vision, proprioception, or position sense in the toes and feet, and vestibular sense. So your balance center is in the middle ear. To do the Romberg, what you have to have, I always was taught, when you do the Romberg, you have people have their arms out in midair and close their eyes. That's really not necessary. It's not part of the test. That's a combination of pronate or drift in Romberg. So the arms can be by the side. So you get people to stand with their feet together. You have them close their eyes. I tend to have an arm in front of them and behind them, so if they fall down, I'll be able to catch them. So, do beware. People do fall when you do the Romberg, and it's really bad when they fall in your office and hurt themselves. So beware. You're doing this for a reason. So with the eyes closed, the visual input is removed, and you can develop some instability. So if there's increased sway, or if they fall off their stance, that would be a positive Romberg. And that does indicate some vestibular disease or posterior column vibration proprioception disease, so peripheral neuropathy. So, as I said, be ready to catch people when you're doing the Romberg. Fair warning. So stand with feet together, arms to the side, eyes open, look for sway. If they're so dizzy that they can't stand with their eyes open, you can't do a real Romberg test. Then you're dealing with something else like vertigo. So you can't really do a Romberg unless they can stand steady with their eyes open. Then they close their eyes. So it's present or absent. Present if there's marked sway and you're really worried that they're going to fall, or if they can't stand in one position and have to move their feet. So you would say Romberg present or Romberg absent. The get up and go test. So that's so what we're doing is we're going from simple tests to more complicated tests that give you more and more information. So the get up and go test was developed in 1986, and I think this is what I and my family doctor do in a very informal way when we walk people from the waiting room. So essentially it's designed to assess mobility, balance, locomotor performance. It standardizes, it's an attempt to start to standardize what physicians and I are doing when we're walking people from the waiting room. So what you do is you place a straight back chair 3 meters from a wall, so facing a wall, and the back of the chair is against another wall. Have a chair that's not leaning back, that's kind of straight back. Ask the senior to stand up without using the arms for support, to stand still for a moment, to walk towards the wall, turn around without touching the wall, to walk back, and to sit down without using the arms of the chair if possible. So what are you looking for? You're looking for the speed with which they rise, whether they struggle when they're trying to get up, whether they do have to catch themselves and push themselves up. See if they're having to really lean forward when they're getting up, or whether they can just stand straight up. Look at your emotional state too. Are you ready to catch the person? If you're ready to catch the person, that's telling you something right there. When they're standing, what's their stance? Are they leaning to one side? Are they swaying quite a bit? Are they struggling to stay upright? Are they complaining of pain? Do you see them wincing when they stand up? So always do that. Always look for pain while you're doing these maneuvers. And when they're walking, look at the the height and width of their steps. Are their steps regular and even? Are they maintaining their balance? If you're worried, you may want to walk beside them, ready to catch them at all times. I can't tell you how often I've caught people during some of these tests. Once again, are you worried they're going to fall? Look for some asymmetries, abnormal arm swings, hesitancy, slowing or stopping. Look at the step height, and then you might be looking at a few of these different disorders, but I wouldn't make a diagnosis based on the get up and go test. These are screening tests to tell you there's a problem or there's no problem. These are not really diagnostic tests in my mind. And if someone has path deviation, one thing that's not in here is you would also think of stroke, right? A weakness on that side. So watch how they turn. When people are turning in any mobility test, in my experience, stand on their outside. They tend to fall outwards. Right? If you're inside the turn, you'll have trouble catching them. So stand on their outside and catch them if they fall. So you're looking at the speed of the turn, the steadiness, the number of foot placements. Once again, are you worried? And I wouldn't use this. I put this in here because some people do put that there. This can give you suggestions to the diagnosis, like Parkinson's, peripheral neuropathy, cerebellar disease, but I wouldn't use this diagnostically. It's more of a screening test that there is or is not a problem. And then sitting down, look, do they descend slowly and in control? Do they just fall into the chair? Do they have to really lean forward? Do they have to hold on to the wall or the chair? And always be aware that they might fall off the chair and sit off the side, so be careful to make sure they land on the chair. So these are the general measures that we're looking for. So when they're getting out of the chair, normal would be no slowness, less than 4 seconds. 4 seconds is already fairly long. Mild abnormality, they need some assistance. And moderate to severe, they're using assistance throughout rising. They're holding onto the chair, leaning forward throughout. Standing, normal would be no signs. Mild would be a wider stance, irregular posture, just doesn't look normal. And moderate to severe would be severe trunk sway, 5 to 10 degrees, reaching out to hold on to things, doing the wall furniture walking thing. Turning, no hesitation, about 2 to 3 foot placements to make the turn. Mild deficits, 4 to 5 foot placements, and moderate to severe, 6 or more foot placements. Maybe holding on to the wall, holding on to items to make that turn, or holding on to you as you're trying to help them not fall. And then sitting down, normal would be smooth descent, not using the chair for support. Mildly abnormal, slow descent, a little hesitant, a little nervous, and moderate to severe, really having to hold on to the chair, not controlling the descent, falling right into the chair, almost missing the chair. Be close to the chair, have your knee close to the chair, make sure you nudge them into the chair if they're going to fall off it. Once again, really bad when they do that during your examination. So the scoring can be normal or abnormal, so dichotomous, or it can be, you can put it on a Likert scale like this: normal, slightly abnormal, mildly, moderately, severely. So you can create your own Likert scale. The timed up and go is one step further. People are trying to make the test a bit more sensitive and specific. What they found is even the get up and go, there was a lot of variability between people doing the get up and go and how they rated it. So they're trying to create a bit more reliability with the test. So once again, it looks very much like the get up and go. They standardized the chair height here. You have your 3-meter path. You have a stopwatch. How many people here have a stopwatch? So not a lot. So that might be a little bit of a barrier to using the timed up and go. They can do one practice trial. They should wear their normal footwear, not just their running shoes, but what they wear around the house, and their usual walking aids. And you're not supposed to help them, but I would stand by them just in case. So once again, they're sitting, and you go, ready, steady, go. And you watch them go. So watch them walk the line in the floor, turn around, walk back to the chair. So there's no limit. It can take as long as you can tolerate doing the test, but after a while you might call it a failed test. So healthy people would do it in 10 seconds or less, and some very frail people can take up to 2 minutes to do it. So this was studied to look at what are the cutoffs. So as I said, the timed up and go between ages 60 and 80, the timing is about 10 seconds or less. When you get over 13.5 seconds, then you have a problem. So the outreach assessors are good at doing this test. I don't do this test in my practice, but perhaps I'll try it more often. We're really interested from hearing from the group here whether this is something that's realistic or feasible in your practice. And then the 30-second chair test. This is one I just learned about while this study has been going on. And you're going to see it's one of the outcome measures that's, or one of the assessment measures that's recommended. So you have a chair with a straight back without any armrests, about 17 inches high. You have a stopwatch again. So everyone here who's involved in this may have to go and buy a stopwatch. So we'll fund that. We'll fund that. Wow. There's a couple of dollars left in the budget, so that's good. So the instructions: sit in the middle of the chair, place your hands on the opposite shoulder crossing the list, feet flat on the floor, keep your back straight. When I say go, stand up, then sit down again. Stand up and sit down. Do it as quickly as you can, as often as you can, and do that for 30 seconds. And then what you do is you count the number of times the person goes all the way up, not part way. Make sure they're not cheating. So you're like a coach. You're encouraging them to do it the right way. Record the number of times, and if they're sort of halfway up, you're going to count that as a stand at the very end. So we are interested in your feedback on this and the other tests. So a number of ways to assess balance mobility. Don't forget, if there is a balance problem, if there's near falls or falls, don't forget the medications, the postural hypotension, and that pain control is adequate. Sometimes pain control, all you have to do is take them from PRN Tylenol to regular Tylenol, or Tylenol arthritis, a long-acting Tylenol every 8 hours. So just make sure they have regular analgesia before you go too much further on your assessment. Visual acuity. So people who are legally blind don't fall. You know, they've learned to compensate for their falls unless they become so blind they can't see anything, and it's overwhelmed the ability to compensate. People who tend to fall due to vision problems are people who've had a sudden vision loss, they've had a retinal tear, a stroke with hemianopsia, and they haven't learned how to compensate yet. People with vision problems can start falling if something else is going on, if they lose their cognitive ability to compensate for their vision problems. So they develop delirium or depression or dementia, and they no longer use their walker, they no longer avoid those dangerous stairs, they no longer do the compensatory measures. Once again, eventually the vision problems can become so severe that people can't compensate. So the common vision problems we all encounter are glaucoma. So in glaucoma, first you lose your peripheral vision, and it's like looking through a tunnel. Cataracts and age-related macular degeneration, where you lose your central vision. So you lose your cones. I remember CCC, cones, central, color, and cone. So you lose your color vision, which are your central cones. People with macular degeneration will start to look at you sideways, so they'll look at you with their peripheral vision using their rods, their peripheral rods. So they can see, if you look at someone beside you sort of sideways, you can see that they're there, you can see their face, but you can't really discriminate any facial expressions, you can't read writing. It's very, very gross vision. If you have someone with macular degeneration, just as an aside, who has a sudden vision loss, they say, my vision just changed this morning, you call their ophthalmologist right away, and you say, this is what happened. Invariably, they'll say, bring them down, there might be retinal tear, they might need laser therapy. That's an emergency, so they should go see their ophthalmologist immediately. E. Other neurological impairments. So now we're getting into areas that I do a lot of, and these are areas that blow up quite a bit, and it's incredible how much is in there. So the other neurological are almost anything. So the 3Ds, make sure it's not dementia, delirium, depression. How do dementia, delirium, depression cause falls? Number one, apraxia. In some types of dementia, like vascular dementia, you can hit the parietal lobes, you can have early apraxia. In Alzheimer's, in the medium to later stages, you'll develop apraxia. So you're not placing your feet where they should be, and then you start to fall. You see that in delirium. We see that in hospital quite a bit as people are recovering from delirium. I watch them working with the physiotherapist, and they're very apraxic. Their feet are not landing where they should. You know they're going to fall if someone's not holding on to them. Other things that can happen, as I said, decreased compensation. They're not using their walkers when they should. They're not doing the safety measures, and they're going in dangerous areas they wouldn't have before. And then in delirium and depression, slow mentation. They're not reacting as quickly as they could. Other things, neurological, very self-evident: stroke, subdural, subarachnoid bleeds, cerebellar disease, normal pressure hydrocephalus, spinal stenosis, myasthenia gravis, ALS, peripheral and autonomic neuropathy, and Parkinsonism. So how do I remember this? I just go from head to toe, and I try to imagine any neurological disease that can occur as you do cuts. So stroke, subdural, subarachnoid, normal pressure hydrocephalus, dementia, delirium, depression, vision, and I just slice the body, and I go through all the cuts, and that's how I remember things, because I could never memorize a list like this. And then if you do have someone who has Parkinsonism, if they have the slow resting tremor either in their hands or their chin or their feet, if they have slowness of movement, akinesia, bradykinesia, if they have cogwheel rigidity, and falls, this is the differential that we go through. So the first is Parkinson's disease, what neurologists would call idiopathic Parkinsonism. So they have the TRAP, the motor symptoms, tremor, cogwheel rigidity, so the rigidity is kind of a ratchety motion like that, akinesia, bradykinesia, so they're slow, and postural instability, falls, which is how you might see them in this pilot. Some people will have vascular Parkinsonism. They have what looks like Parkinson's disease, but they're not responding to Cinemet. And what you see on the CAT scan is you see either multiple strokes all over the place, or you see strokes in the basal ganglia, the area that Parkinson's affects. I wouldn't jump to the diagnosis of vascular Parkinson's just because you see those strokes, because you'll see those strokes in people who are normal. It all depends on where they hit the basal ganglia precisely, and you'll see that in people with real Parkinson's. So I would assume it's Parkinson's disease first and see if they can respond to Cinemet. Drugs. There are some drugs that cause Parkinsonism that we talked about, the antipsychotics and the GI drugs, Stemetil and Maxaran. So what do antipsychotics do? They push down dopamine and they make you Parkinsonian. What does Cinemet do? Cinemet pushes up dopamine, and if you overdose on Cinemet, you're psychotic. So really there's a spectrum of effect here, trying to get the right dopamine level that's not causing too much rigidity or psychosis. Lewy body disease or Lewy body dementia is the fourth type of Parkinsonism. So this is dementia. These people come in with hallucinations, fluctuations. So it sounds like delirium. When you hear hallucinations, fluctuation, that's delirium. But what they tell you is, yeah, mom's been having hallucinations. She's been seeing or hearing things that aren't there for 18 months. Then you go, it's hard to believe you'd be that delirious for that long. You really should be in the hospital if you're that sick. So then you think about things like psychotic disorders or Lewy body disease. People with Lewy body dementia or any of these really don't tolerate antipsychotics very well. So if they're on this list, I would avoid antipsychotics. In Lewy body dementia, the cholinesterase inhibitors really take away the hallucinations very well. And I should have given a disclosure at the beginning. I don't work for any for the pharmaceutical industry, and I don't take anything from them. So this is a sort of an independent opinion. Lewy body dementia is very, very responsive to the cholinesterase inhibitors. It doesn't seem to be helped very much with memantine. We'll often try memantine out of desperation, but the cholinesterase inhibitors do take away the hallucinations. And then progressive supranuclear palsy. So I see a lot of people around the table with glasses, and I've had glasses since I was 5. When you have glasses and you change your frames, and they're not the same size, sometimes you trip a little bit because the frame's not where you're used to having it. People with progressive supranuclear palsy have a similar problem. They lose their downward gaze, so they can't look down, and they present with falls. Eventually, they lose their upward gaze and then their lateral gaze. So they develop an ophthalmoplegia. They can't move their eyes. So just seniors in general, some seniors can lose their upward gaze in isolation. That doesn't mean anything. But if you lose downward first and then the others, then you have to really worry. So whenever you put in a consult to a neurologist for Parkinson's, what you really want to see is they evaluated the extraocular movements. That tells you they're working through a list including PSP. After the eye movements stop, people develop rigidity of the neck, rigidity of the trunk. So they look quite frozen. They can't move their neck or their trunk, and they can't move their eyes. They look very locked in. They develop a lot of depression, anxiety, psychosis, and dementia. It's a horrible, horrible disease. In a family practice of 1,500 to 3,000, you might have 2 or 3 people with PSP. It's a really, really a rough disease to have. Next is late Alzheimer's. It's someone you know has had Alzheimer's dementia for many years. They're in a retirement home, maybe looking towards long-term care, and you're starting to see a bit of a tremor. We don't tend to treat that. The drugs that are used for Parkinson's to prevent falls either increase dopamine, so they would cause psychosis in someone with Alzheimer's, or they're anticholinergic. And in Alzheimer's, we try to do the opposite. We try to push up acetylcholine. So we tend not to treat that. And then finally, the multisystem atrophies. So these are people, they look Parkinsonian, but when you look, they also have peripheral neuropathy, they have cerebellar signs, spinal cord signs, and as physicians, we don't know what's going on. We consult neurology, and neurology says, yeah, it appears multi-systems are affected. And the one that often comes into, not often, but that does show up in the internal medicine wards is Shy-Drager, because that has severe autonomic neuropathy, so severe blood pressure drops. So where do you go in the hospital when you have low blood pressure? You go to internal medicine. So they see Shy-Drager. The others are less common, olivopontocerebellar degeneration, striatal-nigral degeneration. It's just for you to be aware, there's a whole list of things that look Parkinsonian. So when people say there's Parkinsonism, it may not be Parkinson's disease, it may be one of these others. Neurologic impairment still, vertebrobasilar insufficiency. So the vertebral arteries run through the bones of the neck, through the cervical vertebrae, and in some people you can get bony growth, arthritis, that starts to impinge upon those vertebral arteries. So when people move their neck, either rotate their neck or more often look upwards, the vertebral arteries are pinched. And people start to become dizzy and they fall down. According to the textbooks, we're supposed to be seeing diplopia, dysarthria, facial numbness, and ataxia. Maybe the ataxia is the falls, but the rest of them I haven't seen. I'm still looking for that. A lot of people are given the diagnosis of VBI, or vertebral basilar insufficiency, who don't have it. There's something else going on. It's just kind of a speculative or working diagnosis. So when you see that, be a little bit wary. Sometimes when we do the carotid artery Dopplers, they will look at the vertebral arteries and tell us whether they're stenotic or not. So they can be looked at with ultrasound. And the treatment for that is behavioral modification. If you get dizzy looking up, stop looking up. So that, you know, there's no surgery that can open up all those foramens. Vertigo. So this is the normal algorithm I do in my talk. When I go through falls, I do vertigo first, and then I do everything else I've been talking about. I decided not to put vertigo into this talk. You should be aware vertigo is a cause of falls. My sense is, and you can correct me at the end, and if we have time, I do have slides I can go through, but my sense is that primary care is much better at evaluating vertigo than I am, or than any specialists are, except for maybe ENT, because primary care sees a lot more vertigo. By the time they get to specialists, the peripheral causes are gone. The people have recovered. It's central vertigo, and then we refer on to ENT anyways. So I'm not going to get into this unless there's a rebellion at the end and you insist we go through it. But I think you'll be pretty tired by the end. So I don't anticipate that. But it is there. Vertigo is not in the American British Geriatric Society list. And it should be there because it certainly can cause falls. Heart rate and rhythm. So in my mind, I try to simplify things. Essentially, what causes a decrease in cardiac output? Category 1, things that block the blood from flowing to the brain. Number 2, arrhythmias, so things that change the beating of the heart so it doesn't pump enough blood. And number 3, a heart that just can't beat anymore. The myocardium is not good enough to push blood. So blocking blood flow, as I said, I'm very simple. Aortic stenosis. We always listen for aortic stenosis murmur. Mitral stenosis. As I said, if you have aortic stenosis and you're starting to have pre-syncope, syncope falls, you're in the last few years of life unless you get surgery. Subaortic stenosis, so enlarging of the myocardium under the aortic valve. Aortic dissection, so a dissection within the aorta itself that's starting to plug the lumen, the space within the aorta. And pulmonary embolus, so a big clot in the lungs that's preventing blood flow going from the right side of the heart to the left side of the heart. So these are, and I could probably put carotid stenosis in there too. So these are things that are blocking blood flow from going through the heart and up to the brain. Next is arrhythmias, the actual beating of the heart. So tachycardia, so VTach, supraventricular tachycardia, Wolff-Parkinson-White ventricular fibrillation, rapid atrial fibrillation. How does a fast heart cause decreased cardiac output and dizziness? Well, for a heart to function properly, think of it like a bellows that you would use on a fireplace. What the heart has to do, it has to relax and has to open up and accept a full volume of blood, and then it contracts and it pushes out that blood. So there's a bellows mechanism. There's a certain amount of time that's required for that left ventricle to open up and completely fill up. If your heart's going too fast, over 150, the heart's not opening all the way before it has its next beat. So you're not getting the full volume going through. So that's really helped me understand how tachycardia decreases cardiac output, because you'd think the opposite, right? You'd think, well, it's going faster, it should be moving a lot more blood, but it's just not allowing the heart to fill up. Bradycardia, slow heart rate, is much easier to understand. So sick sinus syndrome, conduction blocks. Certainly if someone has a very low heart rate, you're going to be doing ECGs and deciding, do they need a pacemaker? And we do see that quite often. And we have a lot of people come through for assessment of falls, and what they have is intermittent complete heart block. And then they go for a pacemaker and they're cured. Make sure they're not on a medication that can slow the heart. So digoxin, beta blockers, including the Timoptic or Timolol eye drops. In some people, those are systemically absorbed. Alzheimer medications, the cholinesterase inhibitors, they increase acetylcholine. What does the vagus nerve do? The vagus nerve that can slow the heart down, it increases acetylcholine. So you're essentially increasing vagal stimulation. So the cholinesterase inhibitors can cause sinus bradycardia, but they can also block the AV node, so AV conduction. So they can cause a lot of problems with cardiac conduction and cardiac pulsing, and that's why we don't use them without an EKG. Even with a normal ECG, somebody may be 3 months away from their first sick sinus syndrome, their first very low heart rate, and we give them a stress test, and then we find out what's going to happen in a few months. And then the calcium channel blockers. So if they're on these medications and the heart rate is slow and they're getting dizzy and falling, think about these medications. And then carotid sinus hypersensitivity, where you touch the carotid artery, the carotid sinus, and people become bradycardic and start falling down. I'll be honest, I haven't seen that. So maybe I haven't been looking hard enough. It's in the American Geriatric Society and British Geriatric Society guidelines. It's mentioned very prominently, which I find strange because it's not a common etiology. And then very low ejection fraction. As I said, the heart should be, if it's fully expanded, pumping out 55% of its volume. 40 to 55% is mildly decreased. 20 to 40 is moderately. Less than 20 is severe impairment. So if they're less than 20, they're really not moving enough blood. They're just pushing out 20% of their volume of their left ventricle each beat. So you can't expect them to have much of a heart rate. And then vasovagal syncope. So this is the classic fainting, right? The first time you watched surgery, you passed out, or you had a friend who passed out, or they watched a scary movie on TV and they passed out, or they saw blood and they passed out, or they gave blood and passed out. Big emotional upsets. What happens is it increases the firing in the vagus. The vagus slows the heart down too much. Blood isn't moved, so blood doesn't get to the brain and they pass out. You'll see this with urination or defecation, so they can have a vasovagal, or swallowing or coughing. So often when seniors pass out in the washroom and they go to the emergency department, if there's no rhythm on the strip at that time, they can't say they had an arrhythmia, so they say it's a possible vasovagal. Be aware that's just a working diagnosis. You know, when you're trying to evaluate, if you're not measuring the rhythm at the time of the event, you really can't tell what's going on. So much like I said, vertebrobasilar is a working diagnosis, beware. Vasovagal is a working diagnosis, beware. It's often not the true diagnosis. And then we're getting into some more, so those are areas I think I do fairly well. There are areas like this, the next three that I think I have a lot to learn. So as I said, there are no experts in this area, just a lot of students. So bone health, nutritional review, and I'm going to really rely heavily on public health for this. So Ottawa Public Health has really done a great job in reviewing the literature, and what they recommend is for adults over 51 years old. Well, I'm going to be there in a couple of years. Well, I'm going to have to start taking my vitamin D. So 3 or more servings of milk or alternatives, adequate calcium and vitamin D rich foods, and a vitamin D supplement of 400 units per day. So you'll see different guidelines, and I have some guidelines with me that kind of disagree with this. This is the best synthesis from a local perspective. A lot of people wonder, you know, how can vitamin D prevent falls? Is it just preventing fractures? And there are RCTs and meta-analysis that indicate that there are positive effects of vitamin D that go beyond just bone strength. So we want to prevent falls. When people fall, we want to prevent fractures. But vitamin D apparently prevents the falls itself, not just the fractures. It improves muscle strength, and it may be involved in neuromuscular conduction. So it's doing some other things that we don't really expect. Most of us focus more on the bone health itself. So I'm sorry, the left column here should be calcium and the right column should be vitamin D. So the recommendations from food and or supplement are women should be getting 1,200 milligrams of calcium, and men should be getting about 1,000 to 1,200 milligrams of calcium. So you'll have to look up websites to see, you know, looking at the dietary review, are they getting enough? I can't pretend that I'm great at doing a dietary review, and that may be one of the bits of feedback that we need from you. Is this something you can do, you just do naturally already, or is this an area that you also struggle with, calculating how much calcium and vitamin D people are getting? So that might be an outcome of the pilot. And then on the right side, the vitamin D. So people 51 to 70 years old, women and men, should be getting 600 units, 71 plus 800 units. And as I said, people over 50 years should be getting a supplement of 400 units. So those are the recommendations to date, and we'll certainly welcome your input on how well you can operationalize that. Feet and footwear. Also something we all have to learn about, and I had a lot of help learning about this from the outreach team and from the RGP team. So don't forget, you know, some of us doctors don't like to take off socks and shoes because they're kind of smelly, and you know, we didn't get down to that part of the exam. But it's really, in someone who's falling, it's really important to take off the shoes and socks, and you'll learn a lot you didn't expect about the patient when you do that. You'll see signs of neglect. That may reflect neglect by a caregiver, may reflect depression, may reflect dementia, cognitive impairment. So when you look at the feet can tell you a lot. More specifically, what do you want to look at or look for? Moderate and severe bunions that are really having a lot of friction, causing a lot of pain, significant toe and nail deformities, overriding toes, ulcers. So there may be a room for chiropody here, and that's one of the consults that the algorithm recommends. It's an area of falls that I don't think has enough attention and where we can do a lot for people. Loss of position sense or proprioception, so can they sense if the toe is being moved up and down? And the best way to assess for that is really to spread the toe, have them close their eyes, spread the small toes aside, clamp on the sides of the big toe, and ask them if you're moving up or down. And they should be able to detect about 50% of that. That's really a gross test. The monofilament test that you use for diabetics and the vibration sense with the tuning fork are more sensitive tests. They're going to pick up peripheral neuropathies much more readily, the milder forms. But they may not be as specific. You might be picking up something that's not relevant to falls. So once again, you know, I'm going to defer to your experience as you go through this regarding what you find is most useful. I have my own opinions, but I'm going to try not to bias your opinions too much. Don't forget to not think just about the feet and footwear. The AGS, American Geriatric Society, British Geriatric Society looked at feet and footwear, but look at the whole lower body. So you're looking for pain in the muscles, atrophy of the muscles. Look not just at the feet, but at the ankle, knee, and hip. So you may have quite severe deformities, Charcot feet from loss of sensation, so very deformed feet. Look at pain control, as I mentioned before. I can't tell you how many people. The outreach assessors can now tell me exactly what I'm going to say when they present a case. You know, please put this person on Tylenol arthritis, 1 tablet 650 milligrams TID straight, or 2 tablets 1300 milligrams TID straight, and then we'll assess mobility. So get the pain out of the way so we can assess the rest of the contributors to mobility. If that doesn't work, and if they don't have heart failure, renal dysfunction, or hypertension, consider an NSAID, and if necessary, narcotics. You're going to go up the WHO pain control ladder. Don't forget that heart failure can cause changes in the feet. So big, puffy, edematous feet can cause falls. People lose their proprioception. Plus they have these big, heavy feet to lift up. So that can alter the biomechanics and the sensation. The footwear. Many of us, most of us, don't do that very well. If at all possible, and I realize this is logistically difficult, ask them to bring in the shoes they were wearing when they fell. Or ask a loved one to describe the shoes as honestly as they possibly can without causing a fight. Because sometimes the loved ones are fighting with the person you're caring for about the shoes they wear. So you're looking for a shoe that doesn't fit well, where there's movement within the shoe as they're walking. Lack of support, so not laced or buckled or providing some ankle support. High heels are tricky. Some women have been using high heels extensively for years, and they develop shortening in the Achilles tendon. So you really have trouble getting them into low flat shoes. You can try to slowly go down on those heels, but that's a real challenge, and you might need to get a footwear specialist, a chiropodist, someone involved in that type of a situation. Small surface area. So the high-heeled shoes have a very small surface area relevant to flat shoes. So you're going to look at the shoe, you're going to say, is this touching the floor? First of all, is there enough surface area to prevent a slip and a slide and a fall? And then number two, is this a slippery sole? So the shoes I'm wearing right now are very slippery. They're very old, and all the tread's worn out. So that's bad. Or they might be designed that way. It might be a nice patent leather sole that has no gripping features. So if you can, look at the shoe or have them bring it in next time. It sounds small, but if this small thing can make a difference and can prevent a hip fracture or subdural, it becomes a big deal. So the small things make a big difference. Environmental hazards. We're also going to appreciate your input into this. How much can you gauge from the office setting without having someone go into the house? So we do have the benefit of the geriatric outreach team, and they provided a lot of this for me, but I don't see people at home. So relying on reports is very, very challenging. What we should be looking for is some hazards in the home. So poorly lit stairs, especially if people already have vision problems, or ramps, doorways. Stairs that are irregular, that have been adjusted, that are very old, that are not up to code. Stairs without railings. Stairs without marked edges. Slippery floors, throw rugs, loose carpets. Sills on doors that are raised too much and people are tripping over it. Clutter. Low toilet seats. So some people who have weak quads have a lot of difficulty getting off low toilet seats. They actually may need to get a different toilet, one of the larger, higher ones. Lack of grab bars in the bathroom, and then poorly maintained mobility aids. So look at their walker and look at whether it's falling apart. Look at whether the brakes actually work. Look at whether it can be locked in place. Look at whether it's stable, and look at the height. So the height of a cane or walker should be roughly, when they're standing, should be roughly at the crease in the wrist or at the greater trochanter. So what you want, greater trochanter in the hip. So what you want is when they're standing, you want a little bit of bend. You don't want their hands to be fully extended, because then if they put the cane or walker down off a curb, they're going to be leaning over it and they're going to fall. You also don't want a woman to have her husband's old cane or walker that's super high, so her hand's way up here, because the torque forces are enormous. So you want a little bit of bend, about 10 to 15 degrees there, so there's some play. They can go down a curb, but not huge torque forces. So is it well maintained? Do the brakes work? Is it the right size? And certainly refer on to somebody who knows more about canes and walkers to see if they have the right one. Outdoor hazards, and winter's coming, these are just going to escalate. So sidewalks, cracks in sidewalks, at least you can find out about their house. You know, their walkway, their steps going in and out of the house, whether they're maintained, whether there's good lighting, whether there's snow or ice on the walkways, whether they're salting the driveways. Another mea culpa, I remember one winter I fell twice. Why? Not because I had balance problems, so I always listen to the story of the fall. Because I had poor judgment or I was lazy, I didn't salt the driveway. So both times I was carrying the garbage can out on an icy driveway. So listen to the mechanism of the fall and ask, is this a balance problem or is this a judgment problem? It's a judgment problem, but I'm trainable, so that's gone away. It's been cured. And then, you know, long crosswalks in the neighborhood, inability to cross the road. So different ways to approach this. Ask the patient and family about difficulty getting out of bed, getting off low chairs, getting off the toilet, tripping over rugs, thresholds, lighting, and stairs. So these are shorter, faster ways to approach this, and we'll give you a sense of risk reduction strategies. Sometimes a story will at least tell you, I need to send someone into the home. There's something going on here, and I can't fix this from an office. And this is another list that you can look at. This is just a reiteration of what I've been talking about, a different way of framing some of the questions. So I won't go into this because you can read this. It's in the handouts and it's going to be on the website. And then finally, depression. I'm not going to go into depression in great detail. Anxiety, panic disorders can cause falls. So always think about depression, especially if the person's falling. Depression may cause the falls, may contribute, but it also may be the result. They're falling, so they're starting to restrict their activities, not going out of the house, and becoming socially withdrawn. So it's hard to tell if it's cause. Well, the goals of treatment, why are we doing all of this? And sometimes I have to remind myself, prevent falls as much as you can. Preventing all falls is often unachievable. Everybody falls sometimes. Sometimes the environmental stressor is just too much. It was an ice storm, I had to go out, had to let the cat out, and I fell down. Since we can't prevent all falls, we also want to prevent fractures. So if someone is having near falls or falls, if they're at fall risk, do think about a bone mineral density and do think about treating osteoporosis and osteopenia. If they just have osteopenia, calcium, vitamin D. If it's osteoporosis, calcium, vitamin D, bisphosphonate, if they can tolerate it, or some of the other drugs. If they've already had one fragility fracture, which very simply means a fracture that you or I would not have with a minor fall, then you have to think about osteoporosis and treatment. So how do we treat falls? How can we manage this? Is this a one-person show? Absolutely not. You already have a sense of the extreme depth you have to go through. If you know the patient, you can, however, fly through a lot of this stuff. You can say, a lot of this stuff is not pertinent to this person. I know they don't have aortic stenosis. I know they don't have arrhythmias. I can skip over some of that stuff. So what does the team generally do? The physician, the nurse, and possibly the pharmacist are adjusting medications, stopping them for the most part. The two classes of medications we might be starting are medications for pain or medications for Parkinson's. Or if people have orthostatic hypotension, midodrine, some of the other amantine, so drugs that can increase blood pressure. So those are the rare drugs you would start, but usually it's decreasing or stopping the drugs, optimizing control of their other problems like their diabetes, their CHF, and considering the bone density. Occupational therapists, looking at compensatory strategies, planning around the deficits, education, assistive devices to deal with some of the deficits, physiotherapy, balance and strength training, and ambulation aids. I'm not capturing all of what everyone does, just kind of the highlights. Social work is the person living in a house that they can possibly safely negotiate, and maybe they're not. And looking at some support services and maybe some programs that people can go to. Nutrition, as I described with the person with dementia, people are put on cholinesterase inhibitors, they lose 30 pounds, they start to fall. If people have lost a significant amount of weight, a lot of that is muscle. They may also have postural hypotension. So nutrition can sometimes, if there's progressive weight loss, that can become your #1 issue. If you cannot turn around the progressive weight loss and get weight back on somewhere close to their normal baseline, you may not be able to get anywhere. That can become #1. So that's generally what all of us do. I'm missing stuff the MDs do and the OTs do and physio, the other team members do, but this gives you a general sense of how people compensate each other's professional skills. So I'm just going to show you one thing on our website. As I said, we're going to try to download or upload as much of this as we can, as many resources as we can, so that if you want to look at the algorithm, if you want some resources, how do I deal with postural hypotension, it's going to be loaded on this. So go to rgpeo.com, so rgpeo.com, look at the home tab. Under this, look under where the red arrow is, the fall prevention. That will bring you to this page. And here you're going to have fall risk assessment and intervention resources, community resources, and other resources. So throughout this trial, we're going to keep populating this as much as we possibly can. And then this is what I've been talking about. If you really want to get into one of these, we're going to have not only the slides, but we're going to try to link in articles that may be of help if you want to dig a bit deeper in some of the topics. And this will be on the Champlain Health Line, so our main website of resources. So we're going to be building things in, so it'll be iterative. You can go to Champlain Health Line, get to the Regional Geriatric Program website, and vice versa. So you'll be able to go back and forth. So we're going to keep building resources for you, and certainly if you have things that you think are relevant, you should let us know.